Good evening, everybody. My name is Jeremy Pigeon. I'm part of the advancement team. I'm going to do all the housekeeping before we begin and before Colin starts up. Welcome, everybody, to this month's Discover event, part of our NCL in Action programme that is delivered by the alumni engagement team. It's designed to encourage lifelong learning through provoking and insightful events such as this one. I hope you've been to others before, but if you haven't, welcome. Is planning to be a very interesting talk. I've had a sneak preview as Colin tested all his slides before you got here. The programme for all this year is aligned to our goal of looking at AI and how it is impacting our lives, both positively and negatively, and how it's shaping pretty much every aspect and any aspect of our life that you can think of. As you may have noticed when you signed up, the event is being delivered in a hybrid format. So while you're all here in person, which is lovely, we have people online as well. So there will be questions coming in from them and from yourselves as we get towards the end. So as you may have seen on the description when we signed up, and for this evening as well, we're using AI to prevent bowel cancer. In the UK, there's about 16,800 deaths, maybe slightly more, might be slightly more accurate than that, from bowel cancer each year. That averages almost 50 people a day. According to research led by Newcastle University academics, the use of AI in colonoscopies significantly increases the detection of early signs of bowel cancer, which is absolutely brilliant. I'm not going to go into any more detail because I am not the expert here. This is what Colin is here for. I'm going to not read the full speaker bio either, although it's very impressive. I'm just going to welcome Professor Colin Rees, who is the president of the British Society of Gastroenterology, the Professor of Gastroenterology at Newcastle University, and the consultant in South Tyneside and Sunderland as well. So with no further ado, I'm going to hand it.
Thank you. So I'm going to delight you with the twin horrors of AI and colonoscopy this afternoon. So these are my conflicts of interest. So what I'm going to cover is a bit of background on bowel or colorectal cancer. I'll use those two words interchangeably. How we investigate patients, what a colonoscopy is, what polyps are, and then I'll talk about our work with artificial intelligence. So colorectal cancer is the third commonest cancer in the world. The commonest is lung, followed by breast. And there are about 2 million cases of bowel cancer worldwide each year. It is the second commonest cause of cancer death. Lung is first and then colorectal second. And there are about 900,000 deaths worldwide each year from bowel cancer. And as we've just heard, there's about 42,000 cases in the UK and about 16,000 deaths. About 57%, just under 60% of people who get bowel cancer will survive for 10 years or more. And really importantly, at least 50% of cases of bowel cancer are preventable through lifestyle factors. But as we've just heard, that's 44 people die in the UK every single day from bowel cancer. So that's, you know, at least one bus crash a day of people dying from bowel cancer. Like most cancers, bowel cancer is commoner in older age groups. It's very uncommon under the age of 50, but we are seeing a rising incidence under the age of 50. And if anyone wants to talk about that, I can talk a bit more about that later. But essentially, the 60s, 70s, and 80s are the main ages where we get bowel cancer. And that's why we have screening in those age groups. Unfortunately, unlike the Premier League, although maybe not at the moment, the Northeast is at the very top, sadly, in terms of rates of bowel cancer and in terms of poor outcomes from bowel cancer. You could probably reproduce this table for almost every area of healthcare. Sadly, we get the thin end of the wedge in terms of healthcare outcomes in this region. I talked a little bit about prevention, that at least 50% of cases of bowel cancer are preventable. So that's through increasing the amount of fibre in your diet, through eating less red meat, from not being obese, from not smoking, from reducing alcohol consumption and increasing physical activity. So if we could have an impact on a lot of these areas, we'd reduce the incidence significantly. And it's these factors that are the main reason why we're seeing rising incidence in young people. So just to talk a little bit about how you might end up coming for a colonoscopy, which is ultimately where our AI work was. There are broadly two routes that you come to see somebody like me in a hospital. The first is that you present to your GP with symptoms. The second is that you're invited between the age of 50 and 74 to the bowel cancer screening program. And then what we do is you will be given a stool test. That's one of these little, if you haven't seen them. So my pointer isn't working. Oh, it is that, yeah, it is on that one. So these are little tests here that people dip in their stool, and then we look for microscopic levels of blood in the stool. And based upon that, if there's blood there, people are referred for a colonoscopy. So these two pathways are the symptomatic pathway. So that's if people go to their GP with altered bowel habit, with bleeding from the back end, with weight loss, or with a mass, or with a low blood count anemia. And then you go to your GP, and the GP will do one of these fit tests, and if there's blood in the stool, refer you for colonoscopy. The other pathway is through the NHS bowel cancer screening program. I can see one of my former colleagues here, and I remember his retirement due. He told me how much he was looking forward to bowel cancer screening as part of his retirement. So from the age of, it used to be 60 to 74, but we've gradually decreased the age to 50. So from the age of 50 to 74, every 2 years for your birthday present, you will get one of these kits to complete, and it tests the stool for blood. And I would encourage anybody who's of that age to do this. We know this saves lives. And if there's blood in the stool, you'll get a colonoscopy. So this is what a colonoscopy looks like. So we stick a tube, sticks the wrong word, we gently insert a tube through the back end, and we look around the bowel, and these are the kind of views that you see. So this is a really important slide. That what happens in a bowel is you have a normal bowel, and that's what we call normal epithelium here. And then some cells in the bowel decide that they're going to misbehave and go off and behave in their own. All cancers really do this. They behave in their own way, and they turn into these little warty things in the bowel called a polyp. And then over a period of time, a small polyp becomes a bigger polyp and eventually becomes a cancer. Now, not all polyps become cancer, but all cancers start life as a polyp. So that process takes about 10 to 15 years. So you can see that we have an opportunity here that if we can find these polyps, we can take them off and we can stop people getting cancer. So this is a really important part of what I'm going to talk about today. And this is on the left here is a typical example of a polyp. In the middle is an early cancer, and then this is a more advanced cancer that you can see on the right here. And that's what we want to try and prevent. So we prevent colorectal cancer or bowel cancer by removing these polyps, which I'm going to call adenomas. There are different types of polyps, but for the purpose of this, it's only really adenomas that matter. But we do know that some colorectal cancers happen after people have had a colonoscopy. And we've got this really snappy term called post-colonoscopy colorectal cancers, which I will talk a little bit about. And that suggests to us that we've either not taken a polyp off completely or we've missed something in the bowel. And I know this is a complex slide, but this was a really, really important study, two studies that were published in the New England Journal of Medicine about 15 years ago. And they demonstrated that where you find more polyps in the bowel, you have lower rates of these post-colonoscopy colorectal cancers. So if you look at this slide here, up here, these are people that have low detection rates of these adenomas, and they have high rates of their patients getting post-colonoscopy colorectal cancers. And if you have high rates of detection, you have low rates. So high rates of detection are good because it means that you're going to find everything that's there and prevent bowel cancer. And then the second study showed that that actually links to people dying from that bowel cancer. Again, you don't need the details of this, but there's a particular type of nasty polyp, which I will talk about in a bit. And it showed exactly the same thing, that if you find more of these nasty polyps, you stop people getting bowel cancer. So what we want to do is increase the number of these adenomas detected, and that will reduce the rates of these post-colonoscopy colorectal cancers and stop people dying from them. So what about artificial intelligence? Well, as we heard before, artificial intelligence is transforming every element of our lives. When you do a Google search now, it's artificial intelligence that does that for you. Almost everything you look up on the internet now, artificial intelligence does that. And we're using it very widely in healthcare. The thing about artificial intelligence is it doesn't need to go for lunch. It doesn't need to clock off overnight. It can work 24/7, 365 days a year. So we are using it in a wide range of areas. We're using it to scan GP referrals to look at the kind of pattern of words that might alarm us about a patient, that they might have something serious. We're using them to predict responses to treatment, particularly things like chemotherapy. We use it in robotic surgery, and we use it in reporting of X-rays. And an area that we're using in our research is where you have very large data sets. AI is very, very good at scanning large data sets for results. So the sort of AI that we're using in our research that I'm going to talk about now is called convolutional neural networks, which basically is a form of machine learning. And And what you do is you give lots of pictures to this machine of a normal area and an abnormal area in the bowel. It looks at it and it works out the difference between them. And it looks at many, many pictures, and it uses what it learns to go to the next lot of pictures, and it learns all the time like that. And basically, it then tells you whether it's normal or abnormal. And that's the technology that I'm going to show you now. So this was the Color Detect trial, which was a randomized controlled trial. So that means individuals were randomized to either have a normal colonoscopy or colonoscopy with the GI Genius. This is the GI Genius device here, and it fits in the endoscopy room that I talked about. So this is a little polyp in the bowel, and you can see the green box around it. Another polyp, and another one, and another one. So it's found these polyps. So this was the trial to assess the clinical effectiveness of GI Genius colonoscopy in routine practice, comparing GI Genius assisted, or GGC, I'll abbreviate to, with standard colonoscopy. Last little bit of background to this. There's two important measures. The first is the mean number of adenomas. So that's we took the people in this room, we take all the adenomas that we found and we divide it by the number of people in here. So that tells us how many adenomas there are in total. And then the second measure tells me how many of you have one or more adenomas in you. So those are two very important different markers, because what we want to do is we want to find every adenoma in every person, but we also want to find every adenoma that they've got. So that's why we use these two measures. So this was the study. So we recruited 2,032 participants coming for either symptoms, as I mentioned earlier, or for screening. We had 10 trusts across England and 73 colonoscopists. And our primary outcome was the total number of adenomas detected. The people, as I say, were randomized to have their colonoscopy with or without the artificial intelligence. These were the hospitals we work with. So 4 of them were in the Northeast. We do a lot of our research in the Northeast. And then we have some other sites that we work with in Kettering, Morecambe, Bolton, and Wolverhampton. And we're really grateful to all of them for their work on this study. It's very important that when you randomize to two parts of a trial, you make sure the two arms are the same, so that you don't have lots more men in one arm or lots more older people in the other arm, or a different indication. So we randomize before, when people came along for the colonoscopy, we randomized by these characteristics and put them into one arm of the trial or the other. And this is basically just the characteristics of the two parts. So the first arm, the standard colonoscopy, and the GI Genius colonoscopy, and essentially the numbers in these two columns should look about the same. That tells you that both parts of the arms of the trial were similar, and they are very similar, so the randomization worked. And this is the important bit, that we demonstrated a significant increase, and I'll take you through this, in detection using GI Genius. So in the non-GI Genius, we found 1.2 adenomas on average, and in the GI Genius arm, we found 1.56. So that's a 36% increase, 36% absolute, 29% relative increase in the number of adenomas detected. And then this number here is the statistical significance. So this tells you whether this is likely to have occurred by chance or whether it was significant. Anything less than 0.05 is considered significant. So this was highly significant. So this device worked. It showed that we can find more adenomas at colonoscopy. And this is where we looked at it by those two parts. You know, I've talked before about the screening people. So when we invite people or people with symptoms, and we saw a difference in both parts, and it was significant in both, but we saw a bigger increase in screening. And this is where we looked at the number of people that had one or more adenomas. So we saw that in the standard arm, we saw that there was a 48% of people had adenomas, and in the GI Genius arm, 56.5%. And again, that was highly significant. And this was just comparing it by the screening and the symptomatic groups again. Now, I'm going to talk about some bad boys in the colon. These are called sessile serrated polyps. And typically polyps in the bowel have this nice smooth appearance on the outside, but these ones have a really sort of jagged sawtooth appearance. They only make up between 4 and 10% of polyps that we find during colonoscopy, but they account for about 30% of bowel cancers. So these are bad polyps, and it's important that we find them. There are very, very few studies so far. We really only identified this about 10 years ago. So we looked at this as well, and we saw a significant increase in detection of these polyps. It's only quite a small number, about 3%, but if actually the total range of these polyps is 4 to 9%, that's still a significant change, a 3% increase in these polyps. And we saw this really in the screening, but not the symptomatic patients. The polyps we found in this study were generally smaller, so the mean size in the standard colonoscopy arm was 5.78 millimeters, and in the GI Genius 5.18 millimeters. Makes sense. You find smaller things with AI than you do with a naked eye. We categorize our polyps. We call them by names depending on their shape. And the one you saw before would be a 1SP. It was a sticky out polyp. We then have ones that are not quite sticky out, and we have these ones which are quite flat polyps. And what we actually found was that using the artificial intelligence, we saw more of these flatter polyps. Again, that makes sense. If something's sticking out, it's likely to be obvious, but if it's flat, it's much more likely that you might miss it. It's important that we look to see whether we did any harm with the study. And the GI Genius did mean that the procedures were slightly longer, but that again makes sense. If you're finding more things, you're more likely to take longer to take them off. So we did find that the procedure time was slightly longer with the GI Genius, but none of the other characteristics like comfort or complication rates, etc., were any different between the two parts. Now, coming back to this slide that I showed you before, you'll recall that I told you that as adenoma detection increases, the rate of these post-colonoscopy colorectal cancer decreases. And I also told you that as you find more of these bad serrated polyps, the rate of post-colonoscopy colorectal cancer decreases. And based on that, an 8.3% increase in adenoma detection that we found could potentially equate to a 25% reduction in these polyps. In post-colonoscopy colorectal cancer, and the 3% increase in sessile serrated lesions would equate to a 23%. Those are very similar figures. So they help us know that our research is consistent, that the two main areas where we saw an impact would lead to the same sort of clinical outcome long term. So what did we demonstrate? We demonstrated that an increased detection of these lesions and polyps more generally. Typically, these polyps were smaller. We saw a greater proportion of the flat polyps, and it did take slightly longer, but there was no increase in adverse events. So these are highly significant results. We published this in the Lancet group at the end of last year. It's now consistent with other studies that are coming out. And the National Institute of Healthcare and Clinical Excellence will give an opinion on this later this year. This is now being adopted widely. If you have a colonoscopy done by me, I use this all the time. We use this in our department now, and I use it in every patient. And in the United States, you'll be aware there's a big group of hospitals called the Veterans Hospitals. They are now mandating use of this in their hospitals. Just a little word on the rest of our research. Newcastle is really leading the way in a huge number of areas of research. And in terms of our bowel cancer research, we're also doing a large study called Color Cohort that we've recruited around 10,000 patients to, looking at the link between colorectal cancer and the microbiome. So that's the bugs that live in the gut. We're doing a study looking at whether, as well as doing that fit test that we talked about, you should add other factors into it. And we've just completed that study. And we're looking to establish a really big platform where we recruit people across the whole region, those with and without bowel cancer, to our work. And we're going to be launching that this month. And we've also done quite a lot of work on how we measure patient experience of colonoscopy. We produced the world's first measure on this, and this is now quite widely used. So our mantra is that everybody coming for colonoscopy should have the opportunity to participate in research in this region. We pretty much lead the way UK-wide in terms of research in this field. We've recruited about 20,000 patients altogether, and we're really grateful to people like the Sir Bobby Robson Foundation and Parabola who funded our research. So just to finish off, I want to say thank you to all the people that I work with, and above all, to patients. If patients weren't prepared to be part of research studies, we couldn't do research.
I'll just grab a floating mic just so that we've got stuff. Just something more like that. Yep.
Thanks, Colin. That was very interesting. The piece of kit, is it compatible with Olympus and with the other one? I can't remember what the other one is. And how much does it cost approximately?
So it costs about £40,000, but given a colonoscope costs about 30,000. It is compatible with all the kits. So this is the world everybody is moving in now. So all the manufacturers are making it. The advantage of this one is it's generic to all the manufacturers. So if you have Olympus kit, they have their own system. Fuji, Pentax are developing their own systems, but this one works across them all. So you only have to buy it once. The other thing about it is, like you'll probably know with all AI, is it is such a moving field that there's a software update every few months where they update it with all the images that have gone to it in the interim to make it ever more accurate.
Hi, thank you. You said you were looking into other things to add to a fit test. What's the false negative rate of a fit test?
So the area under the curve for a fit on its own is about 92. So you know, yeah, it's not bad. But the problem we have with fit is actually the false positives rather than the false negatives. So it's a pretty good test at ruling out bowel cancer, but it picks up a lot of people that don't have bowel cancer. And so as it's being, so fit really, we started using it before, we used it for screening before the pandemic. But during the pandemic, where we couldn't colonoscope people and we had to find a way to triage who was at risk, etc., we started doing fit tests. And really, since the pandemic, it's come into all practice, and it's now standard practice that you used to go to your GP and you'd be referred for colonoscopy. You now go to your GP and you get a fit, and then you're referred for colonoscopy. But what that means is that lots of fit kits are given out, so we have a lot of false positives, particularly younger people. So what our ColoFit study has shown is that if you add in a few like a blood test and look at the blood count, the platelet count, and the size of the red blood cells, along with the patient's age, and add that, you miss a tiny number more cancers, but you reduce the need for colonoscopy by about 25%. Given we do 700,000 colonoscopies, if we can reduce the need for unnecessary colonoscopies, that means we can do people quicker and we can extend screening and things like that. So at the moment, we've got a really pressurized resource, and we're doing too many people that don't need a colonoscopy. So almost all of our work at the minute is around trying to identify the most at-risk people that we need to do a colonoscopy on.
Yeah, the balance right.
I'll come to online and then I'll.
Okay. I wonder if you could say a little bit more about the machine learning aspects. What I'm thinking of is when you're analysing loads of images, is it just local, or are you using international studies to feed those images in as well?
Good. I'm glad it wasn't too technical a question, because my skill is in colonoscopy, not in artificial intelligence. So yeah, so this was international data that was used for this. Literally thousands of cases to try and help them find the difference. And then, as I say, it learns as it learns. So as we get more data, it's fed in and it learns more. The next stage, I skirted over it briefly because it's not that important, that I mentioned these cell-saturated adenomas, and there are other completely benign polyps. And the next stage, so there's two elements to AI here. One is detection, which I've talked about here. The other is characterization. Can you use the artificial intelligence to tell the difference between those? Rather, at the minute, we take them off and send them to the lab. But if you can tell in situ, you don't necessarily have to take off the ones you know are completely benign. The evidence it is going to get there. It will work better than the human eye. And we did a trial about 10 years ago to see whether the human eye could tell the difference, and we're not very good at it. Artificial intelligence will span that gap, but the evidence isn't there yet. It will be within the next 5 years, though. You probably saw when I put the image up, there was some words underneath. That's the start of it trying to tell you whether it's a bad polyp or not. But that's definitely going to be the next stage.
Online.
Question from online. How much red meat should we be eating? We're told to eat less, but what does that mean?
I mean, the kind of recommendation is that you don't have red meat more than sort of once or twice a week. It's not an exact science. I can't give you the number of grams, but the World Cancer Research Fund recommends not having red meat more than once or twice a week.
Why are you stopping screening for polyps at 74? And do serrated polyps have the same symptom profile as adenomatous polyps?
I'm going to answer the second question first. We don't know whether polyps cause symptoms. We just don't know that. But it's a question that we ask all the time. At what point between that picture that I showed you of a normal bowel and a cancer, at what point do symptoms start? And at what point does bleeding start? And what point does microscopic bleeding start? We don't know that because we take these polyps off, so we don't know. We are doing some pieces of work at the minute to try. So I'm really keen that we do a study at the minute where we do this fit test as we do now when people come for the colonoscopy, and then repeat it a few weeks after to see if the fit has gone back to normal, because that would be a helpful indication if we've taken a polyp off that it was the polyp that was bleeding. So we don't know. Cell-ulcerated polyps progress to cancer more quickly. The typical period of time is 10 to 15 years for a polyp to progress to cancer. Cell-ulcerated probably do it in more like 2 to 3 years, potentially 2 to 5 years. So there are more unstable. There's something called microsatellite instability, which is where cells are very, very unstable and are one of the main issues, certainly in cancer in younger people. And these cell-ulcerated polyps tend to go down that line. Why do we stop screening at 74? It's really it's a health economics question. It's as simple as that. That when screening was introduced in 2007, it was 60 to 74 because and that was where the health economics stacked up. As we're getting cancer in younger people, the health economics now stacks up 50 to 74. It's based upon, I mean, I'm not a health economist, but there was a huge health economics report on it basically. And given that a lot of what we do is find polyps to prevent people getting cancer, if they take 10 to 15 years to develop into cancer, you've got to factor in things like frailty and risk of other disease, etc. You can, of course, opt in. So you're invited up to the age of 74, but at any age, you can ring up one of the bowel cancer screening centres and say, I'm 80, will you send me a fit kit? You can choose to opt in.
Okay, can I follow that?
Yeah.
Are serrated polyps related to familial cancers more than nomatous polyps?
Probably. Yeah. So about 30% of bowel cancers have some genetic element to them. There's only about 6% that have a very defined gene associated with them. So if you have one first-degree relative who's had bowel cancer, your risk of bowel cancer is doubled. We don't know a lot of the details about cell-ulcerated and their genetic risk at the minute, but it's probable that they fall more into the genetic risk element of this than the lifestyle factor risk of it. But we're doing some work, and in our 10,000 patients that I mentioned, we have 459 patients with cell-ulcerated lesions, and we have blood for genetics and stool for microbiome on all those people. So that's something that we've got somebody in an office just up there somewhere looking at right at the minute, and we expect to publish on that by the end of the year.
Another online question. Will capsule endoscopy be able to use this technology?
So artificial intelligence is used in capsule endoscopy. Capsule endoscopy is very good for the middle part of the bowel that we can't get to with a tube. So you can stick a tube down the top way or stick a tube up the bottom way, but the bit in the middle is very hard to get to. So capsule was first developed in that area. It's very good for finding things in that middle part of the bowel. It's also being used at the top end and the bottom end as well. It was brought in significantly during the pandemic for the bottom end because of the issues we had with capacity with colonoscopy, and it's being evaluated further at the moment. It's good for picking up significant things like cancers. It's probably not quite as good for all polyps. The other disadvantage is that clearly it can't take polyps off. And you saw in our control arm of our trial, we had polyps in 48% of patients. So if you have a capsule and you have a polyp, you then need to come back for colonoscopy to have that polyp taken off. So capsule has a role. I think we're still trying to work out exactly what its role is, but artificial intelligence will definitely be used in capsule reporting. At the minute, it takes, there's somebody who's an expert in capsule here, it takes, what, 2 to 4 hours to report a capsule still, does it? Not as long as that? All right, 1 now, okay, fine, all right, quick. Simon always says it takes him 2 to 4 years. So 2 to 4 hours. So again, I mean, reporting capsule endoscopy is a little bit like watching paint dry. You sit and look at a screen and you're looking for the abnormality that might flick past your eye. if you can get an artificial intelligence program to do that for you, why wouldn't you do that? That's why it's revolutionizing radiology, because, you know, radiologists sit and look at X-ray after X-ray and report them, but they get tired, their eyes get tired, they get distracted. Artificial intelligence will do it far better and can do it 24/7.
Thank you.
I'll go along the front and then up to the back.
Super quick question. If I understand what you said correctly, it's about 10 to 15 years from a polyp developing into post colonoscopy cancer. Will it be 10 to 15 years before we know removing a greater proportion of small polyps has had a material outcome in?
Yeah, good question. So yeah, so it's 10 years from a polyp to developing, 10 to 15 years colorectal cancer. Yes, is the short answer, which is why in the bowel cancer screening program at the moment, although it's been going about 15 years, we're only just beginning to get the impact of that in terms of incidence and mortality, because there's a lag, particularly as I mentioned that about 60% of people will survive 10 years with bowel cancer. You're absolutely right. So we are talking about how we did another trial of a device to improve detection at colonoscopy in about 2012, and we're just having conversations at the minute about going to the cancer registry data for all of those people to see if any of those people got bowel cancer. So you're right, it's going to be a bit. That's why those studies with the graphs that I showed you of Michael Kaminsky and Doug Corley's paper in the New England Journal of Medicine, they looked at massive data sets. One was from Poland and one was from, I think it was Kaiser Permanente, and they have big data sets. Polish have a really good registry, so they were able to look over a long period of time and see what happened many years down the line. But you're right, in terms of seeing, it would not make any sense for our data not to be the same as everybody else's, that if you take adenomas off, you prevent colorectal cancer. But in terms of actually demonstrating that practically, you're right, you need a long period of time.
Air polyps are not problematic, but you said some of them are flat and it is hard to detect them.
Mhm.
How can we say it is detecting earlier?
Because those polyps, although they start flat, we know that there are 4 types of polyps that are the most likely to be missed. They're flat ones, they're small ones, they're these sessile serrated ones, and the ones in the right part of the bowel, so this bit, which is the first bit from the back end. So we know that those are the ones that are more likely to be missed. So if we find those, the assumption is that we're not missing them and we're detecting them and preventing bowel cancer.
And do you know if the AI could be used to detect other issues on the bowel, like endometriosis lesions?
I'm not aware of any specific work. Well, okay, so what AI generally does tells the difference between normal and abnormal. It's not as good yet at characterizing abnormal, because if you think there are many images of normal versus abnormal that you can feed to AI, it can only characterize things if it's got enough of those. So if you ask it to tell the difference between different type of polyp and you give it enough, it'll be able to do it. If you give it enough images of endometriosis versus polyps, etc., then it will eventually be able to take that. Endometriosis is tricky because endometriosis tends to be on the outside of the bowel more. So actually, I've scoped people that I know have got endometriosis, that have bleeding from endometriosis, and the colon looks normal because you can't see anything. You can see if it's bleeding, but you can't see it because it tends to occur on the outside of the bowel. So I think eventually, potentially yes, but not in a minute.
Another online question. Do you have any collaboration with the immunology department to read the susceptibility markers of bowel cancer, such as the P53 oncogene?
So I'm not a geneticist. We work with the genetics department. We work with Sir John Byrne, who many of you will know, who set up the Centre for Life. We work quite closely with him, a guy called Richard Gallen, in terms of genetics. We haven't actually started the genetics analysis of our work yet. We have about 5,000 DNA samples stored, and but we don't actually have funding to do the genetics work at the minute. We have it for the microbiome work, so we're looking to get funding to do that. So the short answer is yes, we're working with them, but I can't answer the specific question.
I would love you to discuss the increased rate in the under 50s.
Okay,
Particularly if there's a gender difference and an automatic assumption that you can disprove is obviously increase in waistlines and a relative increase in the lad and ladette culture, certainly in the northeast.
Okay, so early onset colorectal cancer is one of the big challenges. I was in London on Tuesday. Myself and a guy called Kevin Monaghan from St Mark's have set up a collaboration of about 50 UK researchers to try and address this. We met up here in October and we met in London on Tuesday. Bowel cancer is commoner in men than women. Significantly commoner, and early onset colorectal cancer, so that's cancer under the age of 50, is commoner in men than women. We don't fully understand it. We don't. So possible factors are obesity, increased alcohol consumption, and a less exercise. There's also, we think that the microbiome, so the guts, the bugs in the gut, is important, but what we have at the minute is the association between those things and early onset colorectal cancer, but we don't know about the cause yet. So we have about 8 work streams of research looking at that at the minute. We are, St Mark's in London has kept all of its colon cancer specimens going back to the 1930s. So we're going to look at each decade from then and look at whether the cancers are displaying different cellular patterns, different genetics, etc., different blood patterns. We're doing work looking at twins studies. So there's a really big twins study led from Imperial College, and twins work is clearly a really interesting way of trying to work out whether it's genetic versus lifestyle, particularly where lifestyle diverges after childhood. A whole load of things. So basically we have a lot of questions, but to answer your question, we had 3 patients presented on Tuesday. One had colorectal cancer at the age of 35, one at 22 and one at 25. And they are the exception. They're absolutely the exception. They were all thin women who presented. So it's clearly not the whole story. Medicine is only ever about saying what the typical risk factors are, but they don't apply to everybody. And for every person who falls into the typical, I'll see somebody who's totally atypical, and that's, well, not for everybody, but you see atypical people as well. So lifestyle has almost certainly got plays a major factor in it, but probably the effects that we're seeing now aren't demonstrated here yet, because if people are getting early onset, obviously those people are slightly different, but if they're getting in their 30s and 40s, it's not what's happening now, it's what happened in the 1980s and 1990s that influenced them. So looking at that is obviously really important as well, but it's probably the main area of trying to understand bowel cancer that lots of people are working on.
It brings up the lack of diagnostic awareness. Think about these things in young people.
Yeah, and it's really difficult because one of the patients that told their story had a tragic story where they'd been to the GP many times and presented with stage 4 bowel cancer at the age of 22, which is tragic. But seeing it from the GP's perspective, being married to a GP, they will see 1 or 2 cases of cancer of any description a year. So they'll probably see 1 case of bowel cancer every 3 or 4 years. In a whole practice, they'll see 1 early onset colorectal cancer in all of their careers. So asking them to, 1 in 14 GP consultations are with gastrointestinal symptoms. So expecting a GP to pick out the young person that's got the cancer from all the other patients that they see with altered bowel habit is incredibly hard. So that's why we need to be looking at things like genetics, at fit testing, at the microbiome, and at the sort of things that lots of us are doing research on to help the GPs out so they can help identify which are the at-risk people. Because if you see a 22-year-old who's lost weight and got a bit of diarrhea, bowel cancer is going to be a long way down your list of possible diagnoses. I think the message we're trying to give is, if those symptoms continue and they're repeat presenting, don't rule it out, because it could be. Okay. Thank you. Thanks so much.
do the closing spiel and then everybody can go. It's like, obviously, first things first, thank you again to Colin for coming to give us his expertise and his knowledge in this area. I don't know about everybody else, considering I'm a complete layperson, I found it fascinating that AI is being able to make such a difference, and it's such a relatively early stage of using that technology. So hopefully it'll just get better and better as it gets more accurate at picking up those lesions, which is absolutely brilliant. If you do have any feedback about this event, any event you come to at any point, please do leave them by emailing the events email inbox. We're always very grateful about stuff that went well. Anything we could do better, always very, very grateful. This is the final session for this year's Incident Action event. We do encourage people to keep a lookout on our website, on our emails for things that are coming up next year. We're in the midst of developing the theme for next year. So watch this space to see what we're going to talk about, hopefully with a range of interesting articles next year as well. And apart from that, thank you all for coming. Thank you for giving up what is a very lovely sunny Thursday afternoon to come and listen to a very interesting lecture. And I hope to see you all again at events very soon. Thank you very much and good night.